Good afternoon, everyone. I'm just going to give folks a minute or so to join the webinar, and then we'll get started. So we're very excited to have all of you here. If you'd like to introduce yourselves in chat with your name, maybe a job title, maybe what state you're in, because I know we have people from across the country joining us today. So that'd be lovely to know where everyone is from. All right, it's 12:01. We're going to get started. So welcome, good afternoon, and welcome to the 2023 Winter and Spring Third Age Committee webinar series. This is the first session of our webinar series for this year. The Third Age Committee, for a little bit of background, was created in the late 1990s by Health and Human Services professionals from across New York State who were committed to advocating for and spreading awareness of the needs of older adults with IDD, or intellectual and developmental disabilities. I'll be using the acronym IDD today, through educational activities. My name is Laura Robinson, and I am the current chair of the Third Age Committee and the program coordinator for the Finger Lakes Geriatric Education Center at the University of Rochester in Rochester, New York. So just a few housekeeping items. There are two very important buttons on your toolbar. Please use the chat button to type hello, introduce yourself, again, with a name, job title, agency, location, whatever you'd like to share. We'd love to know who's in the audience today. And then there's a second button, the Q&A button. We would love for you to use this to type in a question for the presenters. And we will probably hold questions until the end, since we do have a panel presentation for today. Our moderator today is Frederick Wetzel. He is with us, but not able to speak. So I will be your moderator today. My apologies for the last minute change of plans. So now I will introduce the folks on our panel today. First, we have Dr. Vincent Siasoco. He is a board-certified family physician. He specializes in the care of patients with intellectual and developmental disabilities. He is an assistant professor at the Albert Einstein College of Medicine, and he is also the director of primary care at the Rose F. Kennedy Children's Evaluation and Rehabilitation Center at Montefiore and medical director at ADAPT Community Network. He's a very busy man. And Dr. Siasoco is also on the board of directors at the American Academy of Developmental Medicine and Dentistry. He's a clinical director for Special Olympics and chair of the Special Olympics New York Health Advisory Council and co-chair of the OPWDD, or Office for People with Developmental Disabilities, Medical Task Force here in New York State. Ruth Benjamin began her career in 1974. Her passion has been to work with and advocate for those with IDD, their families, and support staff. She has dedicated 33 years to fulfill this passion at Heritage Christian Services as the Director of Health Management and Research for the past 30 years. In this role, she provided leadership to both nursing team and dietitians, as well as medical oversight for 400 individuals with IDD. And during this time, Ruth obtained board certification in geriatrics, rehabilitative nursing, triage nursing, developmental disability nursing, and legal nurse consultant. She is an active member of the New York State Developmental Disabilities Nurses Association and was one of the first 100 nurses to receive certification as a CDDN. Additionally, Ruth serves on the Regional Mortality Review Committee and is the acting treasurer for the Third Age Committee. In January of 2022, Ruth began serving as a board member of the DDNA. She has also served as a member of the advisory board for the Complex Care Center. Another aspect of Ruth's professional contribution includes participation in the development of IDD curriculum and instruction for nursing students at St. John Fisher College here in Rochester, New York. Presently, Ruth is an RN consultant in the area of aging and end-of-life planning. And we have Dr. Amanda Lapreme, who oversees intensive behavioral services for inpatient and outpatient care at the University of Rochester Medical Center in Rochester, New York. Dr. Lapreme is a clinician and director with expertise in supporting individuals with IDD within the hospital environment and in their communities. She has extensive experience with training, system analysis and transformation, and establishing equity for those with differing needs across environments. She has previously served as a PI on state and foundation grants to address gaps in access to care for those with developmental disabilities. Dr. Lapreme is the Director of Intensive Behavior Services at the University of Rochester Medical Center, a program that focuses on establishing systems of care to reduce mental health or behavioral events for those with IDD. Dr. Lapreme leads numerous initiatives that involve training development and integration of best practice for individuals with IDD in healthcare settings. So we are thrilled to have this panel of experts here today, and I will now turn the floor over to Dr. Vincent Siasoco.
Thank you, Laura, for the wonderful introductions. Thank you for having us here. So welcome, everybody. So as Laura said, I'm a family physician. I'm based in New York City, Long Island area. So I've been working in the DD field for some time now. So Laura, if you can forward the next slide. So looking in the chat box, I see there's a lot of folks here that have experience with this population. So I apologize if I'm preaching to the choir. I always like to start off talks just to kind of give a basic definition of the individuals we're talking about. So those with intellectual disability, based on the CDC definition, is basically a term used when there are limits to a person's ability to learn at an expected level and function in daily life. It can be caused by problems that starts anytime before a child turns 18 years old. Some examples include Down syndrome, fetal alcohol syndrome, Fragile X syndrome. Now, a developmental disability is a group of conditions due to an impairment in physical, learning, language, or behavioral areas. Some examples of developmental disabilities include those with spina bifida, autism spectrum disorder, cerebral palsy, Down syndrome, ADHD, and intellectual disability. And it's important to note when we're talking about these two definitions, these two types of conditions, one doesn't always correlate with the other. So for example, somebody with cerebral palsy doesn't necessarily have an intellectual disability. Somebody with autism may not have intellectual disability. So it's important to note the differences of the conditions and the signs and symptoms that come with each. Next slide, please. So just to give some data, based on studies, it's been noted that approximately 6.5 million people in the US have an intellectual disability. It's been shown in reports that among adults with IDD, 2/3 have two or more comorbidities, including obesity and chronic mental health needs. Some studies show that more than 40% were diagnosed with 4 or more chronic conditions in addition to the IDD diagnosis. It's also been noted that in an individual without IDD, aging is not really accompanied by high rates of medical and functional problems until the age of 70 to 75 and above. Whereas in a person with a disability, these problems can present 20 to 25 years earlier. The average lifespan of those with IDD unfortunately remains substantially lower than in the general population, although overall they are living longer lives than in the past. Compared to the non-disabled population, their lifespan is still remains lower. The World Health Organization reports that those with disabilities are more likely not to have preventative cancer screenings, are more prone to obesity and high blood pressure. Adults with IDD are nearly 4 times as likely to incur high annual healthcare costs than those without IDD. Next slide. So as a family physician, especially as an adult family physician, I think one of the challenges, especially when the new patients come to me for a new evaluation, they're transitioning from their longtime pediatrician or any other type of service that they get. It's really important for me as a primary care physician, I always tell this to my students and residents also, is to really develop that relationship with the individual. And communication, again, I know I'm preaching to the choir, is really the foundation of patient care. And it's always important for me to know the individual, what's their speech, how do they communicate? Is it verbally? Is it through sign language? Is it through writing, letter boards, voice output devices, pictures, even facial expressions or gestures? Any way I can glean in terms of how I will be able to best communicate with them, for me with them, and them with me, I think that's very important. Baseline traits and characteristics, I think that is very key. It's always very important. Whether you're a social worker, OT, physician, when you have an individual, especially an adult coming to you for the first time, it's important to know what their baseline traits are. Their cognition, their communication, their neuromuscular function, their sensory function, their mental health, their behavior. I know, when I give a talk to my medical students and residents, I'm always talking about the vital signs and that sixth vital sign. You always hear about blood pressure, respiratory rate, temperature, oxygen status, but sometimes the behavior, just little gestures here and there, can be enough to give an indication to the caregiver, to the physician, of what may be or may not be going on with the individual if they're nonverbal or able to express themselves. Next slide. So again, as a primary care physician, taking care of the adult population, it's so important to know where they also come from. When we talk about social determinants of health, what support do they get? What type of environment are they living in? Who's helping them? Are they independent? Are they in day programs? So when I think of adult patients coming to me for their primary care, I'm always thinking of their background and who's taking care of them or will be taking care of them after they leave my examination room. So I look at individuals with DD that those live in the community. I think of what kind of supports they have. So are they independent? Do they live with a family member? Are they independent with home attendants? Do they have a connection with a care coordinator? How do I get the history, the medications? I always want to communicate with the patient directly, get all the information from them as much as I can, but there may be some situations where I'll have to go to the caregiver or I'll just call the pharmacy to get a complete medication list to reconcile it. Also, it's important for me to know not only where do they live, but what else are they doing during the day? What keeps them active? Or are they active? Are they in a day program? Are they working? A lot of my individuals are working part-time, fortunately, since the pandemic, and some, unfortunately, are just staying home waiting for day programs to accommodate them. Those that live in a group home have obviously a different set of supports. As you can see, they have direct support professionals, they do have nurses, but it's also important to note that group homes are not nursing homes or assisted living facilities. And I'm always trying to educate, again, my residents, my students, and even fellow physicians to make sure that they understand the difference between a group home, a nursing home, and assisted living facility. And you'll hear more about those individuals living in a group home from my colleague, Ruth, after my presentation. Next slide, please. So as a primary care physician, family physician, we're basically a generalist. We're kind of, we do as much as we can for everyone as much as we can. So when I take care of a patient with adult developmental disabilities, I want to make it sure that I'm looking at the individual systematically, right? Making sure, can they see, can they hear? Are they able to speak? Are they able to be mobile? And how do they get about this? And what supports they need? When I think about the complex nature of the body, I always want to go through systems. It sounds cliche, but it really takes a village to take care of this patient population. So for example, when I talk about cardiology, I'm concerned about an individual that may have Down syndrome, because with certain conditions, certain other co-occurring conditions can happen too. So somebody with Down syndrome may be prone to congenital heart conditions. We want to make sure we get EKGs. Gastrointestinal. Unfortunately, a lot of individuals with IDD have issues with constipation. You see that across the board, whether they have autism spectrum disorder or cerebral palsy. So that's something to note. Dysphagia, aspiration is also a concern with this population, especially those with cerebral palsy. I always want to make sure, are they doing okay? Any problems with their swallowing? I'll ask the caregiver sometimes, do they notice anything? So if somebody with CP comes to my clinic, they're nonverbal, they can't advocate for themselves, I'll ask the caregiver, well, how are they doing while they're maybe eating breakfast or lunch? Are they able to swallow or okay? Are they coughing? So make sure that there's no signs of any dysphagia or aspiration. When I think with this population, I see a lot of vitamin D deficiency, earlier onset osteoporosis, and osteopenia. And the reasons why are multifactorial. Unfortunately, they have sedentary lifestyles. They may not be able to get out as much as we would like them to. Diets, but also medications can increase the risk of an earlier onset of osteoporosis and osteopenia. So it's very important to make sure that preventive screening tests are done. So DEXA scans are ordered at an earlier age with this population than, say, in the non-disabled population, again, depending upon the risk factors. Again, depending upon the conditions, we want to make sure that we are screening for other conditions. So for those that may have Down syndrome, they may be more prone to thyroid disorders. So I want to make sure that the annual exam, I'm getting a thyroid level on a regular basis and monitoring that. Neurologic conditions, again, unfortunately, a lot of individuals with IDD have seizure disorders. That's commonly seen in the population. Earlier onset dementia, again, could also be seen in those with Down syndrome and also other individuals with DD. So you want to make sure that as you get to know the adult, they are also aging. So adulthood is maybe anywhere from 20 to 30, but they are living longer lives. But we want to make sure that they're living healthy and quality lives. So what I see is, especially those that maybe live in a group home, understanding where the line is between intellectual disability and maybe new onset dementia is very important to keep track of that. Next slide, please. Again, as I said, it really takes a village to take care of this population. Those patients with cerebral palsy that may have spasticity, I'm always reaching out to the physiatrist, PT, OT. We want to make sure that we are working together to make sure that the individuals are getting the therapy that they need. Decubitized skin breakdown, that's so important, especially with those populations that utilize the wheelchair. We want to make sure they're being monitored properly, they're being turned in position properly, and those that go to schools, that go to day programs, we want to make sure that those orders are placed in those programs. They know how to address those needs when they are not at home and when they're not in our exam room. Urinary incontinence, UTIs, it's another issue that we are always vigilant about. We want to make sure we're monitoring that before it escalates. A lot of individuals, for example, with urinary tract infections, you and I, we may have burning when we urinate, abdominal pains, back pains. It may be kind of textbook in terms of how we would present with the UTI, but maybe somebody with spina bifida would present differently. A lot of patients who have spina bifida that come to me for their care, they'll let me know when they feel a UTI is coming on. And usually it's the sign of a strong urinary odor. And that's the red flag that they have a UTI coming on. So it's always important to listen to the patient. They know their bodies the best, of course. Unfortunately, our individuals, they also have co-occurring mental health and behavioral health disorders. So you'll unfortunately see that. We need to make sure that we advocate that they get proper women's health care and oral health care. I always say when a patient comes to me for their annual physical exam, I always say it's not a complete physical exam until they see their dentist or their women's health care provider if it's warranted. So we want to make sure that everybody's getting preventative care. We want to make sure that all the systems are being looked at. And when a specialist is needed, the specialist is part of the team taking care of that individual. I have patients where I may refer them to cardiology, endocrinology, or they may be followed by neurosurgery. So we all have to work as a team and make sure that we communicate and coordinate properly. Next slide, please. So again, in summary, communication, of course, as we all know, is very important. Understanding the baseline traits, I think that's very key. There have been a number of times where I've been fortunate enough to develop the relationship and get to know the patients, but have seen situations where there may be new group home staff or may be new physicians where you have what's called diagnostic overshadowing occurring. That's what we want to avoid. So what happens with diagnostic overshadowing is that there may be a behavior, for example, some individual who's nonverbal, who has autism, lives in a group home, can't really convey what's going on, and he's new to the group home, and maybe all of a sudden he starts hitting himself in the head, and the staff think it's more of a psychiatric issue. So it's a behavioral issue. So they may send that patient to the psychiatrist before they send them to the physician, the medical physician, to rule out any medical issues. And they're thinking, oh, it's a psychiatric issue. Let's increase the dose of the psychotropics or add something on. Come to find out, if you go back to the medical or dental, it can be something as simple as a tooth infection or a sore throat contributing to that. So you want to avoid that diagnostic overshadowing, attributing those conditions to just the intellectual disability or the psychiatric diagnosis. And then accommodation and access is so key. I think the care coordinators, the workers, the home attendants, I mean, they do all that they can. I think some of the challenges that I see is, when I refer someone to, say, for example, gynecology within my hospital system, unfortunately, I don't know every physician in the system, but I always want to make sure that at least if I refer them somewhere, that the exam room or the doctor has height adjustable exam tables, has a Hoyer lift, or even has enough staff to make sure that the patient will be able to get on the exam table. Want to make sure there is access and understanding of what my patient's needs are when I refer out. So I think that's also very important too. I find those individuals that I take care of that live in a group home, the group home staff will do their best to coordinate, make the appointments. But I always ask the DSPs to make sure that wherever they're going to be seen, especially if it's a new visit, that they do have access for the individuals that we're going to be providing care for. And again, comprehensive continuous care coordination. I think that's key to quality primary care for adults with intellectual and developmental disabilities. So, thank you.
Vincent, thank you so much for that comprehensive talk about primary care for older adults. I now welcome Ruth Benjamin to begin presenting as well. I'm trying to spotlight Ruth. Hopefully you can see Ruth. There we go. And we'll move to your slides.
Thank you. Hello, everyone. I've been asked to talk a little bit about PCP appointments for the aging adult. And I think first and foremost, you want to do a little research to find the right PCP. And when I say the right PCP, we have a lot of physicians that are great physicians, but we're looking for somebody that really has an interest in the IDD population and that will really take the time to, to examine and to talk with the person themselves, the staff, and really make sure that we are giving a holistic plan of care. So when I look at finding the right physician, I'm going to look at what is the age of this person, what are their diagnoses, what specialists do they already have in place, because all of that will somewhat affect the physician that I'm looking for as a PCP or a primary physician. I can tell you, and I just did this, I spent a good 3 hours just calling and talking to different doctors' offices and really trying to find a particular doctor, a good fit for somebody related to her diagnoses and everything that goes on with her. And it wasn't an easy task, but I finally did find somebody and I'm really excited about that. But we want to consider then the age, their diagnosis, what specialists, the holistic approach to care. And one of the ways that we can help ourselves do this is ongoing networking with different physicians, developing those relationships with the physicians and other care providers, because sometimes you can get little hints from, some of the other care providers that you work with of who we might ask to consider as a PCP for somebody. So is the PCP then familiar with caring for people with intellectual and developmental disabilities? And if they show an interest in that, it is, if you're a nurse, it is our responsibility then to work with them and help them understand the IDD population, maybe if they haven't done that before, but they really would like to care for somebody with IDD. And I've been a part of doing that, and it can be very rewarding, and it can be rewarding to those physicians as well. Check out the accessibility of the office when you are looking for a new physician. We want to make sure that the office is accessible, that there are Hoyer lifts, that there are tables, and sometimes that just isn't going to happen. And we do the best that we absolutely can. There have been times where we've actually offered to bring a Hoyer lift to actually get somebody on a table for examination. So, we want to make sure the accessibility is going to be there. We want to talk about the office hours and after hour visits and calls. That will help us decrease the number, hopefully, of ED visits that somebody has, and have a conversation with the office personnel themselves. Were they considerate? Were they easy, approachable? Did they answer the phone, or was there a recording? All of those things. I kind of look at those things as, yes, this is a good place for us to enter for care, or, I have a pause in some of those things. And then making sure too that you're involving the person that you're supporting as much as possible. So when you're choosing a physician, or maybe it's not going to happen so much in choosing, but when you actually see that physician for the first time, making sure that you're talking to that person and asking them, how do you think the visit went? Do you like the physician that you're seeing, that you're going to see? So really involving them as much as we can. Next slide. So when we talk about the appointment itself, it's very courteous, and we should make sure that we're there on time for appointments, hopefully 15 minutes early in case there's any paperwork that needs to be filled out, and making sure that we can speak to any of the questions or concerns that might come up in the appointment. So being well prepared for an appointment. So do we have the med list? Do we have the treatments that they're receiving? Do we have the other specialists that they're seeing? Again, we want to make sure that there's as much medical history as possible there to give to the new PCP. We also need to follow the protocols that are in place for your particular agency. So for some agencies, they bring a chart. For some agencies, if we can, we bring a very small notebook that just has the consult form, the insurance cards, any information that's requested by the RN. Think about the needs of the person when you're going on an appointment. So is it somebody who needs something to keep them busy? Is it somebody that's going to need a snack? Maybe they need extra clothes, with them. Just really looking at the needs of the person themselves. Ensure that the consult form then, when you go on that appointment, is completed by the physician, and don't be afraid to read it back to the physician to say, so this is what you would like us to do, or this is the new orders that you're asking for. That way there's really good communication, because communication says it all, right? If we don't have that good communication and build those relationships, we're not going to have the experience that we want. And we have a lot to do with that. It's a two-way street. Making sure that we don't sign for any kind of procedures. And that's something that we really need to stress with the staff in the homes, that if they go to, let's say, a dermatologist, and the dermatologist sees a mole that they want to biopsy or whatever, they shouldn't sign for that procedure. The doctor needs to stop and call the guardian and get a phone permission by phone to go ahead and do the biopsy, or there's times where we just set up another appointment. So it's not going to get done that day. And I understand that. And that's not something we like to see, but it really needs to be the legal guardian or the person themselves. If they have the ability to sign for procedures themselves, that's great too. I did want to mention here too, that you're going to hear more and more about the New York State Family Healthcare Act that allows people to make their own medical decisions with support of somebody who's called a supporter for that person, or their healthcare agent. But that's coming, more and more of that. You're going to see it where the person themselves is involved and they are actually making the decisions with somebody just supporting them. And that all goes back to people with developmental disabilities have the same rights as everyone else. So that's something that we're going to see changes with that in the upcoming year. So look for those things as well. And then next slide, please. Sorry. What to do after an appointment. Obviously, we want to make sure that the person that we're supporting is taken care of, whether that means bringing them home and caring for them or taking them back to work. We want to do that usually and let them know what happened on the appointment. And it's that verbal communication that is so important. And then getting the directions of the RN. It's also a good time to decide who's going to call the family about those appointments. And a lot of that is related to what the appointment was about and what needs to be done going forward. If it's a routine appointment, usually we have a med liaison in our agency that will call the family and give them an update. But if there are different diagnostic testing, different things that the physician wants, then it might be the nurse that calls, because who else is going to better answer the family's questions and concerns. And, I really tend to not put that on the staff, because it kind of puts them in a spot where they may not know the answers. So again, just to create that good communication. And I learned that, to be honest, I learned that the hard way, way back when I started. And it was a person who the doctor had said that the person had cysts. And when the staff reported it to the family, they called it tumors. And it just so happened that that family had another daughter who had cancer. And it was really not a good situation. So I learned right then and there that, you know, it really is based upon what happened in the appointment and who should really follow up with that appointment with the family if the family is not there. Sometimes it can be the person themselves that calls their guardian. I think the more communication with the person that's involved, the better. You're also going to make sure that there is a medical progress note written with any directions from the physician. And of course, following your agency protocols with that, whether it goes into a computer system such as Therape or another system, you know, that, or if it's still on paper, but a good medical progress note needs to be written. Verbal communication of any new orders to the staff around you or as a nurse to the staff. Remember that verbal communication, again, is the best form of communication. If we want people to do what needs to be done, they need to understand it. So it's a great time if you're the nurse to be able to communicate to staff and you know, talk with them and really let them know why you're asking them to do what you're asking them to do. That is so important. You're going to have a much better outcome if they understand the whys. And next slide, please. So just some important reminders: involve the person supported as much as possible in their appointments before, during, and after. That appointment is about them. So some of you have probably heard the saying, if it's about me, don't do it without me. And that's really important when we talk about appointments and what's going on medically with somebody. You really want to try to involve them. If possible, ask the person involved what they thought about the appointment, how they feel about the provider, etc. I think that's very important. If you're a staff member, let the RN know how you felt about the appointment. You know, did the physician treat the person as an adult? Did they talk to the person and address needs to the person themselves? And then, you know, if there was something like a physical that was supposed to be done, did the physician find the assistants and did we get that person on the exam table and really be able to examine that person properly, or did they try to do a physical in the wheelchair? And it does happen. So, you know, those are the kinds of things that we look for. And next slide, please. And then telehealth appointments. I put this in here because since COVID, you know, there are a lot of telehealth appointments. And what I found was after the big wave of COVID, we're still doing a lot of telehealth appointments. And that's great to a certain extent. But I think it's really important that we're careful in what appointments are being scheduled as telehealth appointments, because you can't do a physical over the phone. You can't really do a good cardiology. You know, the cardiologist can't listen to somebody's heart. They can't, you know, get all the information that they need if it's just by a phone call. So little things, absolutely. Psych appointments, I'm sure that those can be done, but just really making sure that the appointments that are being scheduled telehealth make sense. Find a private area in the residence if those are telehealth appointments and those are going to occur. Involve the person again as much as possible. They should be a part of that appointment, sitting right there and being able to talk about what's bothering them or, you know, what hurts or whatever to the extent that they can. Be sure to send a medical consult form for the physician to sign with his or get his dictation from that appointment. Otherwise, it can look like that appointment didn't even occur. So that's important. Be sure to communicate any new directives and orders. And again, complete that medical progress note with any order changes, etc. So that's basically it. Again, I can't reinforce enough how important it is for medical history, directives. You know, if somebody has a DNR, DNI order in place, all of those things are going to be so important. And making sure that you talk about with the person and with the physician about what's important with them related to quality of life, because I think it's so important to talk about quality of life versus the number of years that the person is going to live. So to some people, it's important to live 70, 80, 90 years. To other people, it's about quality of life. And to families, the same thing. You know, if you talk to some families, that's what they want for their loved ones. They want quality of life, not necessarily the number of, they're not concerned with the number of years. And neither of them are wrong. It's just different for different people. And I think that does it. Thank you.
Thank you so much, Ruth, for that. And as Amanda is pulling her slides up, I just want to remind everyone, if you have questions for any of the speakers, please feel free to drop them into the chat at any time, not the chat, sorry, the Q&A feature at any time. And Amanda, I'm turning it over to you now.
All right. Hi, everyone. Thank you so much for having me. I'm Amanda Lapreme, and I'm going to talk to you a little bit about behavioral health for adults with IDD in primary care. So I think, you know, we've heard a lot about the considerations as it pertains to medical health and medical visits, and that is so critical for, you know, all of the things related to those we work with. Unfortunately, though, we also see a lot of challenges as it pertains to mental or behavioral health for our individuals with IDD. Specifically, we know that if you have IDD, you're 2 to 3 times more likely to actually have a mental health condition. Most often that is depression and or anxiety, but that does not preclude individuals from having the same exact potential for other mental health or behavioral health conditions that the typically developing population does. We tend to find within the primary care world, when folks are bringing up issues as it pertains to mental or behavioral health, there's an overemphasis on controlling and managing challenging behaviors or pharmacological interventions, as opposed to truly treating the underlying mental health conditions through therapeutic interventions. And there's often a misunderstanding that mental health interventions or therapy may not be accessible for someone with IDD, given verbal or cognitive abilities, and that's simply not the case. And then unfortunately, what we see is that there is an increase in crisis events for individuals whose mental or behavioral health is not well addressed, which creates even further health inequities as it pertains to their health. So it's sort of a vicious cycle. When we look at also the 2 different systems of care, the mental health system of care and the intellectual disabilities of care, they're often vastly different systems with vastly different outcomes. And I think this is one of the reasons our individuals with co-occurring IDD and mental health comorbidities often sort of fall through that crack, right? Whereas our intellectual disability system focuses on habilitation, mental health system actually focuses on rehabilitation. In intellectual disabilities, we focus on self-determination. In mental health, it's about recovery. We have and focus broadly on a developmental model, and mental health focuses on a medical model. We look at the individuals we serve as consumers. We're with them for their life course, which is where in mental health, again, consistent with that medical model, it's a client or a patient. And then lastly, and I think most importantly, in the intellectual disability system, we are very well aware of a long-term systematic approach to support the long-term needs and goals for our individuals. Ruth, as you were just saying, that quality of life. Unfortunately, the mental health system often promotes short-term approaches to fixing an issue. You know, the other thing I sort of want to point out is that this really brings us to this question of treatment versus medication. So one of the biggest challenges, right, is when you are faced with a patient who has IDD and a co-occurring mental or behavioral health need, is that the first kind of request is always, what is the medication going to be? Now, medication is an incredible tool to help support someone's ability to access their life. But medication does not teach how to cope. It does not teach someone how to advocate. It does not teach self-regulation. It may make someone more available for therapy or interventions, but it is not going to teach a skill. And that is the difference between medication or coping and treatment. And I actually put in this quote, which I love. Well-meaning caregivers and providers often hope that a psychotropic medication will be a magic pill, but the evidence does not actually support these expectations. So as we're thinking about mental health within the primary care world for our patients with IDD, I encourage you to think of not just a pharmacological intervention, but what kind of therapy, trauma-informed care, function-based plans are going to help support adaptive skill development and prevent crisis. So there are two types of challenges I want you to be aware of as we kind of go down this journey. There are mental health challenges that are internalizing, and that there are those that are externalizing. So our internalizing challenges are those behaviors directed inward: sadness, anxiety, PTSD. We tend to see this higher in females. And then there's our externalizing challenges, behaviors that are directed outward: oppositional defiance, ADHD, conduct, impulse disorders, generally higher in males. Both are equally catastrophic for our patients. Unfortunately, we all tend to see that individuals who have more pronounced externalizing behaviors may get sort of more attention or crisis support, but we can see internalizing challenges being just as debilitating, if not as sort of in your face. So I want to go over some of the common features, and then we'll go over a little bit about treatment. So anxiety disorders are highly prevalent for adults with IDD, and can be co-occurring with things like dementia or increased medical needs. We might call it anxiety, generalized anxiety, phobia, obsessive compulsive adjustment. What we tend to see in this population of individuals is a fight or flight response, where some kind of trigger, right, leads to an actual physical symptom. And we tend to engage in behaviors or other sort of coping strategies to ameliorate those physical symptoms and all of those challenges. There's a bidirectional relationship with this between thoughts, feelings, and sensations. And one of the challenges we get into for our patients with IDD and anxiety is that there's often this circular sort of situation, right? This happens and I feel really, really anxious. So then I do these not great things, which creates more anxiety and more triggers. So then I do these not great things, and so on and so on. So an anxiety disorder can be incredibly challenging for some of our patients as it pertains to their medical, mental health, and behavioral health. We might also see fear, avoidance, outward opposition, irritability, headaches, stomach aches, nausea, lightheadedness, and rumination on a specific topic, repeatedly asking for reassurance. When we're working with patients who have IDD that are coming to us or seeking medical care, how we address that anxiety is going to be essential. So some key things I want to point out for this group is, first off, being curious and validating experiences is always essential for our population. Helping our patients to label their feelings. You feel anxious right now, or you feel like this is not okay. And honestly, I think sometimes we get scared to do that, but don't be afraid of getting it wrong. Asking a question like, is that right? Am I saying how you feel is okay? Providing information to patients who are anxious, but not too much or too soon, is going to be very critical. Offer choices when possible, so our patients can feel in control. That will help kind of ameliorate potentially some of those signals or some of those challenges with anxiety. And then I think this is actually one of the things we do without realizing it, but could be detrimental to our patients. Avoid reassurance. Instead, use empathic statements. Instead of "there's nothing to be scared of," because we're not in the walls or the body of the patient and we have not had their lived experiences. "I can see you're scared, and that makes a lot of sense. Let's work to help make you more comfortable." And that goes back to that validation. So when we're getting a patient who's coming into primary care, or we're worried that their anxiety is impacting their medical or mental health, these are some of the key things that we want to be really thoughtful to. Then we have to look at depression, because unfortunately that's highly co-occurring for our individuals. We may see major depressive disorder, adjustment disorder. It may look like a lack of caring about self, poor hygiene. I get so many referrals for patients and they want me to write a behavior plan to get them to shower or to take care of themselves. But that's just addressing the symptoms. If we don't address potentially the depression or anxiety that's contributing to the lack of showering, we're just putting a Band-Aid on a situation. We may see low motivation, difficulty concentrating, flat affect or crying, fatigue, either sleeping more or maybe even less, low self-esteem, or suicidal ideation. Another thing we might see is bipolar disorders, mania, hypomania, other specific mood disorders. For these patients, we may see elevated mood or irritability, pressure or increased speech, grandiose ideas, increased creative creativity or energy, and a lack of need for sleep while still having lots of energy. And then we also may see impulse control disorders. So we talked about those a little bit at the beginning, but those are some of those really big sort of externalizing disorders. We may call it oppositional conduct disorder, intermittent explosive, kleptomania, pyromania, and so on. We might see overt irritability, defiance, low tolerance for frustration or adversity, inability to inhibit responses, failure to follow social rules or norms, or property destruction or harm. When someone is engaging in and or has a comorbid impulse control disorder or other really big externalizing disorder, it can really overshadow underlying medical challenges. And I think, Dr. Siasoco was talking about that at the very beginning, and I'll touch upon that. But, it is very easy to sort of say it's all behavior, it's all psychiatric, let's treat that. But I think a lot gets missed. And we often miss the right treatment approaches when we are sort of unaware of the impact this may have on someone's medical or mental health. So if you are working with an individual with a mood or an impulse control disorder, it's really important to have a few basic frames. Now, this is very somewhat simplistic into how do you open up the conversation about the intersection of their mental health and primary care. Most of your patients are going to need an individualized approach. And I could do a whole talk on finding mental health providers who understand IDD, but that's not for today. So if you're working with an individual who is going to access to their primary care and has a co-occurring mood or impulse disorder, first off, be curious. Just asking someone what is going on is really important. Nothing about somebody without them. We don't talk over somebody. We don't talk to their caregiver. We talk to them. What is going on and how are you feeling? Remember, we should be assuming people do well if they can. So if someone is having overt behavioral challenges, framing it in the sense that they're experiencing some other challenge. They cannot do anything but what they're doing at this moment, rather than them being manipulative, choosing not to, or being difficult. We need to engage proactively in problem solving with the individual versus trying to solve each issue, offering choices as much as possible. And then just honestly, for the sake of primary care and making sure someone's getting access to their care, my recommendation is never to push forward with demands or requests that are going to result in escalation. We really have to consider what are the must-haves, the nice-to-haves, and it doesn't really matter if we have it, but we're doing it just because it's what we do. Advocating for individualization for visits and for access to care for our patients is really critical. I also just want to bring up the notion of trauma. Trauma results from an event, series of events, or circumstances experienced when an individual is physically or emotionally harmed or threatened. It affects someone's developmental or physical health, and more often than not, our patients with IDD and co-occurring mental health needs have some trauma as it pertains to accessing their medical care. So when you think about the weight of the world that our patients are carrying into each appointment they have with us, each failure in the past, each overdiagnosed or undiagnosed issue, it's critical that we remember that this is a part of the baggage they carry. And our job is to be aware of that and support that. And we cannot separate that out. Again, there's no medication that's going to fix or mitigate the previous impact of trauma on someone at their point in life. So for trauma, we may call this acute stress disorder, PTSD, or adjustment. We may see someone in our visits looking fearful, jumpy, having difficulty paying attention, reporting difficulty with sleeping, being afraid to be alone, or just being hypervigilant and showing some of those signs that would align with anxiety. Our goal is always to provide trauma-informed medical and mental health care. We have to just primarily avoid re-traumatizing somebody. That should always be our goal, whether it pertains to their medical or their mental health. We have to recognize that behaviors that someone may become in, yes, they may be a sign of underlying mental health needs or underlying medical needs. It also may just be a symptom of traumatic experiences. And we have to recognize that if that is one of the reasons that you are struggling in your life, that being treated with respect and kindness and being empowered is the best way to help someone recover from trauma. So how do you create safety within primary care for patients with comorbid mental health? First off, whether you're an advocate for someone, whether you're a patient or whether you're a provider, We should always be talking to the person. Who are we and what is our role? Being clear about what we are able to do or not do and follow through. Be aware of our own judgments, beliefs, and biases. Always provide explanations before procedures and prepare people for transitions. Have comfort measures available. Avoid power struggles, include people in their care, talk about safety, and explore triggers, what to do to cope, and how our medical teams can support coping. It is critical that we get our patients the right type of therapeutic interventions. Now, there are a variety. We have everything from a medical or mental health inpatient to outpatient to partial hospitalization. And our patients may need different things throughout the episodes of their care. Some of these may be available in our communities and some may not. But it's also important to remember there is not one answer, just like there's not one medication that's going to fix. It may be cognitive behavior therapy. It may be acceptance and commitment. It may be naturalistic. It may be community hab-based therapy. It may be vocational. It may be behavior therapy. Most importantly is that any intervention must focus on improving coping skills, engaging behaviors that are problem solving and learning more adaptive ways. Behavioral interventions that only focusing on diminishing those outward challenges are not going to fit the bill. And unfortunately, we often tend to forget that as people age, that they can still learn, that they can still make progress, and we should never stop advocating for that. Most behaviors are due to someone having underlying challenges that we, have to address, or challenges with communication anxiety or coping. Behavior is functional. It serves a purpose. It is not that someone is bad, problematic, or choosing, right, to be manipulative or challenging. Another thing we have to remember, if a behavior is brand new, intense, and comes out of the blue, that is not consistent, right, with a sudden behavioral change. It is typically when that occurs, we have to be aware of potential underlying medical things. Dr. Siasoco gave a great example, and I've seen this. A patient that suddenly comes to the ED with severe self-injury and attacking others, being labeled as psychotic when they may have an ear infection, a dental abscess. It's not always that, but I really do encourage us not to forget that behavior does follow pretty predictable patterns. And if something seems out of the blue and really different, and a caregiver is saying that, respect that, and make sure we kind of look into that. And I think that's something I work on really closely with our medical folks. And then just don't forget, also that pharmacological interventions and modifications can themselves create behavioral challenges. Like, please be aware of polypharmacy. More is not better. It can actually cause more challenges than make life kind of easier. So my last thing in my last 2 minutes before questions is responding to acute challenges, whether you're in a primary care appointment or considering this for your older individuals. When someone is having an overt mental health or behavioral health challenge, please do ignore behavior, not people, meaning it is never going to help in a situation to tell somebody how inappropriate what they're doing is. Like, when you're in fight or flight, hearing that is not going to do anything but exacerbate or be like throwing gasoline on the fire. Validate feelings, whether you think they're real or not. Use positive language. Always tell someone what to do. Please refrain from telling people what not to do. So instead of "don't yell at me" or "don't hit me," like, I really, I need you to have a safe body when we're working together, or I am really looking forward to talking to you about that when our voices are a little calmer. That helps someone's brain organize. Give control and choices, minimize stimulation. So like one person talking at a time. We often, like, people go up and get ramped up and we all go up too, and we need to calm. That will help sort of minimize challenges. And then sometimes you just need to give someone time and space. Like, I'm going to give you a few minutes and come back. Do not threaten. Do not take away coping items or activities. Do not feed into the behavior. Show anger. We are the professionals. Physically intervene if not necessary, or hold unnecessary boundaries. I am your behaviorist, and I'm going to tell you the notion of, well, I told him we had to get a vaccine, so now we have to do it, or he won't see me as, someone with authority. Like, we don't do that anymore. That's an old school behavior modification approach. And we are much more trauma-informed, patient-centered. And our goal is to promote wellness and health and well-being for our patients. And then lastly, I just always encourage a comprehensive approach to behavioral and mental health. It's not just a behavior plan. It's not just therapy. It's all the things that intersect. And I'm happy to, put my email in the chat if you want to talk about this further. And thank you for your time today.
Thank you, Amanda. That was wonderful. All the presentations were wonderful. So thank you everyone for being here. I am going to stop recording so we can do some Q&A in the last few minutes.